All right. So today we have the honor of hearing from Dr. Shafkat Anwar, who is an associate professor of clinical pediatric cardiology at UCSF and specializes in multimodality and advanced cardiovascular imaging. He completed his pediatric cardiology training at University Hospital at Cleveland, Ohio, and at the Cleveland Clinic with with an advanced imaging training at the Children's Hospital of Philadelphia. He also completed a research fellowship year at the NIH in the NHLBI Developmental Biology Lab. As assistant professor of pediatric cardiology at WashU in St. Louis, Dr. Anwar directed the pediatric cardiac MRI program and co-founded the Medical 3D Printing Center before being recruited to UCSF. His research focuses on multimodality cardiac imaging and cutting-edge cardiac technologies, including 3D printing, advanced visualization systems, and biomechanical analysis. He co-founded the UCSF Center for Advanced 3D Plus Technologies and directs the Pediatric Cardiac MRI program. Thank you, Dr. Anwar, for joining us. I'm looking forward to this talk.
Thank you, Joyce. That was a great introduction. You saved me a lot of work, and I'm looking forward to hopefully meeting more of the adult cardiology group in person. So we'll go ahead and get started. I'm calling this talk Redefining Possible in Adult Congenital and Structural Heart Disease, shamelessly stealing the UCSF Health tagline, but hopefully by the end of this talk, you'll have a better sense of why I chose this title. Here are my disclosures. As this group knows well, gadolinium is off-label use in all MRI except for brain. And I am a consultant for Printerprez, which is a startup in the Bay Area that uses 3D printing for developing medical devices. So, my goals for this talk today, and I really appreciate your group extending this invitation. My goal is very simple. It's to get to know your group a little bit better through this exchange of information, and show you a little bit about how we're using these technologies in congenital heart disease and share some cases that we've done in adult congenital and adult structural. Of course, my background is pediatric, but as this group knows well, our pediatric cardiologists have a close collaboration with our adult congenital group, and a lot of my work spills over into basically anything that's complex congenital heart disease. So my main objective today is really to build bridges between our worlds and hopefully have more in-person interactions with your group and maybe do some good work together. The more specific objective is to talk to you a little bit more about what this technology is that we're calling 3D Plus, and more specifically talk about 3D Plus at UCSF, where I think we're really defining this technology and becoming a leader in the field, and more specifically talk about this technology in adult and structural or adult congenital and structural heart disease. I've kept it pretty short. We're hoping to finish around 45 minutes or so, so hopefully there's time in the end for questions. So I think our universal challenge, whether we're taking care of little babies with hearts the size of walnuts or older patients well into their 70s, 80s, et cetera, our mutual challenge is the same. Here at UCSF, we're a referral facility, so we're getting high-risk patients. These patients tend to be highly complex, and when it comes to surgical or other interventional procedures, we have a low margin of error when we're doing procedures on these patients. So I think what unites us all is a common goal to get the best outcome on the very first attempt, especially when it comes to procedures. So a little while ago, I was recruited to UCSF, and kind of coincident with that recruitment, we founded the center that I now co-direct called the Center for Advanced 3D Plus Technologies to bring together some of the more advanced manufacturing and visualization technologies to hopefully take better care of our patients. This slide essentially kind of shows you what we do in standard of care and how that kind of bridges over to these 3D plus technologies. So for the cardiology group, these images will be very familiar. I'm showing you some images of a patient who is squarely in my world, is a pediatric cardiac patient with pretty complex congenital heart disease. And I am one of the echo readers. I also read CT and MRI. And I'll tell you that most of this kid's diagnosis is in this parasternal short axis sweep. About 90% of the anatomy is shown very nicely here on 2D echo. And this is the same patient. This is a MRA, cardiac MRA. And what we're seeing more that is kind of the incremental value of MRA is the extra cardiac anatomy. And I won't belabor all the details of the connections. Let's just say the kid's got some large holes in the heart and the connections to the outflows are quite abnormal. And what the MRI does is allow us to visualize this with much greater detail, but also look at the outside of the heart. In this case, the patient has some kinking of the left pulmonary artery, almost a collapsed left lung, and there is an aortic coarctation. So we are used to this. This is our standard of care. We all, adult and pediatric cardiology, use echo as our workhorse, and we supplement with MRI, CT, angiography, or other visualization techniques. And as a multimodality imager, I will tell you, I'm pretty much agnostic at this point. I do direct the cardiac MR program in pediatrics, so MRI is near and dear to my heart. But frankly, I've arrived at the conclusion that the best imaging modality is what gives the best information with the lowest burden to the patient. And sometimes we do need to combine imaging modalities to get that information. Now, those of us that are imagers, these images will be pretty much in our comfort zone. And experienced cardiologists and cardiac surgeons and interventionalists, we're used to reconstructing these two-dimensional images in our mind. And for our surgeons, when they're in the operating room, they're referencing back to these images when they are looking at the live heart, sometimes the live beating heart, and trying to do some pretty high-risk, complex intracardiac repairs. But what's on the right is what we can do that's better and frankly additive in terms of information. What I'll show you in the rest of the talk is applications of advanced manufacturing technologies like 3D printing or advanced visualization technologies. These technologies show the anatomy in a way that is much more approachable, understandable, even for very experienced proceduralists or cardiologists, and frankly takes a lot of the mystery out of complex anatomy and helps us really get down to business and figure out what the best repairs are and hopefully give the patient the best outcomes. So essentially, my goal is to help you hold the heart and practice the procedure if you're a surgeon. A little bit about logistics. We're spread out across multiple sites across UCSF. We founded in 2018 from a grant from the Chancellor's Office. So our physical footprint is mainly in the Mission Bay Center where I sit. We're across the hall from the operating room and the cath lab here on the second floor. But we have connections, mainly digital connections, but also some physical office space in Parnassus, and we operate cross Bay. We do cases routinely for Children's Hospital Oakland, some printers set up over at Mount Zion, and a very strong collaboration with our VA, where some of my fellow co-founders operate their 3D print center. They do some really nice advanced work, especially when it comes to some implants and such. And our trauma center at San Francisco General sometimes keeps us busy. The group that I help lead was founded as a multidisciplinary group to hopefully bring together the expertise of different pockets that were doing some of this work prior to 2018 in silos, but built up some great experience, and then combining our resources and our knowledge to really get some synergy out of our combined goals. So the founding groups were the Pediatric, so the Pediatric Heart Center, where I'm from. And I've got some really intelligent, advanced 3D plus folks over at Orthopedics who really know materials, printers, and the technology well. And of course, we could not do this without our collaborations with radiology. And Jesse Courtier in particular is a whiz when it comes to advanced visualization with augmented reality. So these are the physician co-directors. And we're a small but mighty team. Our full-time engineer is Michael Bunker. He's on staff with us. And Veronica Reyes is our coordinator. So a lot of the work that I'll show in the rest of the talk is really Michael's work, and each of us have paired with him to do this work as a partnership. And fortunately, in a place like UCSF, we can extend the ecosystem beyond just clinical or beyond just UCSF Health, our physical printers sit within the Fabrication and Design Center, headed by Eric Lamb, which is in Byers Hall. And we've got strong collaborations with the School of Medicine, both in the Makers Lab, but also the Department of Anatomy. And these collaborations, I think, really bring more of an educational and research aspect to what we do as well. So that is who we are, and this is essentially what we do. We use mainly two different types of technologies. One is physical 3D printing, where we use high resolution medical grade 3D printers to produce physical models. And we do a lot of our work electronically as well, with virtual surgical planning, and then displays that take our routine two-dimensional images and basically magnify them in ways that is difficult to appreciate through traditional visualization. So using technologies such as AR, VR, or MR, we get different use cases out of the different technologies. But I think just as important as the resources of computers and hardware and software are the people resources that we have. I frankly consider us a consult service. We're not a billable service, but we're here and our DNA is extremely clinical. So as a cardiologist, I'm working hand in hand with the surgeons and the interventionalists to essentially serve as a bridge between the medical world and the engineering world that can essentially reproduce anything. So, it's a pretty powerful technology, but those of us that help run the center basically serve as the translators to translate the clinical question, to match it with the technology, to hopefully make it as applicable to the patient's needs as possible. A little bit about our tour. This one snapshot kind of encompasses our operations here in Mission Bay. Again, this is in San Francisco, so our physical footprint has to be very small as far as square footage, but we squeeze a lot out of the space. So I'm sitting in the center right now, where we've got several computers set up with computer-aided design and other segmentation and modeling programs that help us make 3D models. And we've got a couple of printers here that we can use, but frankly, most of our high-end printing happens across the street at Byers Hall. And then we have the complement of AR, VR, of MR technologies in the room, which we use for basically whatever the case requires. And this is kind of a cornucopia of the types of cases that we do. We're a multidisciplinary center, so obviously I focus on hearts, but I focus on also all things pediatric. And we kind of have served multiple different subspecialties at this point in time. But for the purposes of this talk, I'm just going to focus mainly on cardiac. So in order to learn about cardiac 3D printing, I'm just going to take a bit more of a deeper dive into the technology. So this is our surgeon here, Mohan Reddy. This is kind of showing our day-to-day use of these technologies. So Dr. Reddy, as many of you may know, is the head of our congenital cardiothoracic surgical program, and he will often request 3D prints to do virtual surgery. Sorry, not virtual. This is physical surgical simulation on cuttable and suturable 3D printed models. We also do virtual surgical planning, and frankly, at this point, this has moved right into our surgical conferences, and it's part of our day-to-day conversations when it comes to medical care. So this is me kind of taking our group through a virtual surgical plan for one of our more complex patients during surgical conference. And if it's not in the conference, then we're using electronic modeling technologies in the room here. This is just a snapshot of our mixed reality display system called EchoPixel that uses medical holography and mixed reality to do interventional planning. One example of this, just to make it more concrete, is virtual VAD placements. So this is our first virtual VAD fit test. This was a 16-year-old patient, new onset of heart failure, severely depressed systolic function, and found to have dilated cardiomyopathy that needed a VAD as a bridge to transplant. And the patient's LV was just caked with thrombus. So high-risk procedure for VAD placement, and we were able to basically CT scan in a physical VAD. This was our hardware device, and marry that essentially on our mixed reality display system. You can take the VAD, which is exact in the dimensions, take the patient's scan and use the entire three-dimensional volume to very precisely fit where the VAD is going to sit. Our VAD team found this so useful that this is now protocolized. A virtual VAD placement is now protocolized and routine for every single VAD that we're going to place here on the pediatric side. And this is an extension of our technologies right into the operating room. The EchoPixel mixed reality display system is now FDA 510K cleared for intraoperative use. So this is our first live case with that. So the patient is here on the table, and this is again Dr. Reddy. On his loops, there's a very small sensor, and this is the mixed reality display system that's tracking his eyes. And as he moves his head, the CT scan is being displayed here in mixed reality. Obviously, the CT scan was done in advance. This was a patient with very complex vascular malformations where Dr. Reddy really needed to see around blood and around the corner. So having the CT pop up like a medical hologram as he was operating was very useful for the procedure. And again, this is kind of where we are. And we did this almost a year ago now. And finally, of course, we're a teaching facility. So we're using these technologies and bringing them right to our residents, trainees, fellows, medical students. So I'll do hands-on. Of course, pre-COVID, this was easier, but we do hands-on didactics as well as using our 3D projector to do didactic lectures. We're digitizing our pathology specimen collection. So basically taking all the good specimens out of the jars, digitizing them using micro CT and 3D scanning, and making augmented reality models out of them. And this is what I'm showing here on the right. This was developed by Jesse Courtier, one of our radiologists. The app is called Senra, that is downloadable. And essentially what it does is any 3D model that I make, I can display the 3D model right onto a very cheap foam cube. And that cube essentially displays as a full-scale 3D model. And I can view that on an iPad, an iPhone. As you can imagine, that's pretty powerful. You can scroll through the model, you can cut into it. So for education and patient counseling, we've found this technology very useful. For sake of time, these are just a couple of snapshots of our trainees coming through working on different projects. And now I'd like to pivot a little bit and talk more specifically about the use cases of this technology. Just to give you a broad overview, and you're welcome to screenshot this or catch the links later on the webinar recording. But this was a review article that we put out almost 3 years ago now, talking about the use of 3D printing in congenital heart disease. And we actually found a good number of articles, about, I think, over 200 that we cited in the review article. And just to summarize, we're finding that these 3D print and 3D plus technologies is definitely having an impact in our field. And this is specific to cardiac. And it has a different impact on different sectors, if you will, or different stakeholders within our field. So for trainees, you know, this is kind of a paradigm shift. As a cardiology trainee, myself included, I learned to do a cath or other procedures by doing it. I saw it, then I tried it, and then I helped teach it to others. So the see one, do one, teach one is still the way cardiac surgery is taught. And, you know, it is a tried and true model, but perhaps we can do better. And simulator-based learning is a very powerful application of 3D modeling. I can produce as many models of rare or challenging anatomic specimen and let our surgical trainees practice on that. It's much better that they practice on the models before practicing on a patient as their first case. For our experts, they're deriving different benefit from these 3D models. In fact, the experts or more experienced cardiologists, cardiac surgeons, or interventionalists are my heaviest referring physicians. So these experts have realized that they can spend a lot of time just figuring things out in the OR or the cath lab, or they can shorten their time in the OR or the cath lab by making 3D models doing a very detailed procedural plan in advance, and then taking that information directly with them into the OR. And by doing so, hopefully they're avoiding some pitfalls or at least reducing time on bypass. They're being able to see through corners, or sorry, see around corners and essentially through blood, because my 3D model is not obscured by blood in the field. And they can, make contingency plans in advance. This is why we use the models in our surgical conferences to really talk through what happens when plan A fails and we need to bail out to plan B or even plan C. And finally, for our patients and caregivers, these 3D models have a different use case. We use these models to perform informed consent, and I tend to find, talking with the families, that these models are taking out some of the mystery from the diagnoses, because I think we all understand our parents and our caregivers and our patients, they're facing some very difficult decisions. And these decisions are based on understanding of very difficult concepts. Those of us that are in the field have lengthy discussions and healthy disagreements about what to do and the understanding of the anatomy. So you can imagine how difficult it is for our families. But hopefully using these models as a teaching tool and for counseling, we're taking out some of the ambiguity from the informed consent process. I won't belabor the literature a little bit too much, but basically there's been a rise in all types of applications in 3D printing across all specialties, but specifically in cardiovascular applications. So now I'm going to pivot specifically to the adult group, the adult congenital and adult structural group. As you know, this group knows very well, and this is now kind of old data. This is from almost 20 years ago, but 2/3 of the congenital heart disease population are now 18 years of age or older. And again, old data, but at least 1.5 million adult survivors in the US alone. And we know that for those with complex congenital heart disease, adults are now outnumbering children. So a very vulnerable and large and growing population. And for me, this slide still kind of sums it up. The burden of mortality has shifted from earlier eras where the burden was in our neonatal population to now the burden of mortality being in our adult congenital group when it comes to our adults who are living with congenital heart disease. So I think these technologies are very helpful in this population. And I'm preaching to the choir, I completely realize, and I empathize because I read echoes. As our adults get older, we lose our echo windows, and echo is our workhorse. I love echo. However, echo is not adequate in some of these cases where we have very complex anatomy. We also have challenges in the history and in the documentation of these patients. Loss to follow-up, comorbidities, people who've had multiple procedures or high-risk surgical candidates. All this leads to a high-risk population. And we do know that there are risk factors that increase morbidity or mortality, specifically in ACHD, including complex anatomy and the amount of time spent on cardiopulmonary bypass and the number of prior surgeries that we've had. So the goal of applying these 3D plus technologies is to kind of chip away at each of these risk factors and hopefully work towards better outcomes by really cleaning up at least the anatomy and showing you what it is that we'll be dealing with, especially if we're talking about a procedure. So talking about 3D printing, I'd just like to kind of give you a broad overview by talking about the technology very briefly. And of course, I'm happy to answer questions. So this is 3D printing in one slide. We start with a stack of 3D images to produce a 3D volume. I'm just showing you a contrast enhanced MRA here. We do need high resolution. You can use MRA or CTA, but it does need to be high resolution. And from there, basically, I pick out the anatomy of interest, and it really depends upon the case. And I do a detailed anatomic review with our engineer. And this is a process that is a tight partnership between medicine and engineering. And we are fortunate to have an in-house engineer who works for us full time, who happens to be my office mate. So I'll sit down with him for our cardiac cases and we'll do a detailed anatomy review and we'll talk about the goals of the case. And from there, the engineer takes over and does the first pass on the anatomy. Using a process called segmentation, he is essentially defining the anatomy and separating out the anatomy into 3D objects. And we essentially have a recipe for this: inflows, outflows, atria, ventricles, et cetera, et cetera. And all of these are converted into 3D objects. It's a painstaking process. It takes time, but because of our volume, we've been able to become much more efficient as we've spent time doing this. And I will say, I engage with multiple subspecialties, and I think I can say within this group, cardiac is the most challenging. You've got soft tissue, you've got vascular, you've got sometimes intracardiac anatomy that is extremely complex. It is painstaking, laborious, time intensive, but we have been able to bring the time down so that we can turn around models within 48 to 72 hours if necessary. We try not to burn out our engineer by having him turn around models that fast, but we can if needed. Okay, and essentially, again, this is the process of segmentation. Down here on the right-hand side of the screen, he is showing a 3D object that has been generated. And this 3D object is made into a electronic 3D model. This is me reviewing the model in detail and basically giving him feedback. This is a very much requires physician involvement. This is a patient with complex LVOT obstruction, and here the aortic valve leaflets are getting in the way. And I am asking him to please remove that anatomy so I can at least see into the LVOT and see what the real problem is. After that period of feedback and also validation, here our model is to have the engineer do the engineering work, but a physician is always partnered in the process to verify the anatomy and to verify that the medical information is correct. So it ends up being a good partnership. After all that is done, we send our model to a printer, and the printer is exactly what it sounds like. Now 3D printers are available from Best Buy or Amazon, so you may own one yourself. Essentially, what you're doing is building up a 3D object. You're building it up layer by layer until you produce a physical 3D object. And this is just one particular technology. There's many different types of technologies. You clean it off, you remove the supports, and there you are, a physical 3D printed object. And so the rest of this talk will focus on these types of 3D models. So now I'm going to pivot to specific cases, and I'm going to try to show you cases mainly from UCSF. I will say our experience here has been growing. Most of my work has been in congenital, pediatric congenital, but I've the good fortune of knowing some of these great partners, essentially in ACHD, that have sent me very interesting cases that we've done some good work with. And back at WashU, about a third of my volume was in ACHD. So here we go, first case. It's a 33-year-old with D-Transposition of the great arteries with a Senning. This case is meant to show you just anatomy. So the echo is pretty good. It was showing you that the systemic ventricle is dilated and hypertrophied systemic pulmonic ventricle. As expected, I said systemic pulmonic, the systemic RV and the pulmonic LV is kind of pancaked, kind of typical for D-TGA with just an atrial level switch. And here is our attempt on echo to look at the baffles, and here's where things get really difficult. I'm showing this patient's transthoracic echo. A TEE was also done on this patient and provided some more information, but we needed more. So we went to cardiac CT, and for the sake of time, I'm going to skip the CT and just show you the 3D model. And this is the type of information we can produce from the 3D model. Essentially, this is a one-to-one replica. Unfortunately, this is a Zoom talk. If I were doing this live, I would bring over the model. You could touch it and hold it. But essentially, this model is showing a clamshell view of the intracardiac anatomy. So the same thing I was showing on the echo, but just to orient, here's the left atrium shown in orange. Here is the tricuspid valve. Here is the heavily trabeculated and dilated right ventricle. And same thing on this side. Here is the smaller LV back here. And here's some more views of the anatomy from a different perspective. Here is the dilated RV giving off the aorta and an LV giving off the PA posteriorly. And what we can see really nicely here is the Senning baffle. And this is the way pulmonary venous blood is channeled into the systemic RV. and the systemic venous blood will be coming below the baffle here and enter into the LV to go into the PA. So it took me years, frankly, before 3D printing, it took me a long time really trying to understand what a Senning baffle looks like. And when surgeons describe this C shape, I kind of nodded along and I said, yes, the C shape. But until I printed it out and held it in my hand, it was really difficult. And of course, we make these models trying to show the intracardiac anatomy. So they're printed hollow. So this is me inserting a catheter into the systemic RV. It's going out the aorta, and you can see here coming out the descending aorta. So we can do a lot of things because the thing is, these models is an exact replica of the heart. And I can make a comment about an exact replica because we've collected the data on these as far as anatomic accuracy. So combining our experience from two different centers, WashU and here, data across about 8 years have shown that these models are about 90% accurate or above. Most of our models are actually about 95% accurate. By that, I mean the model that I give a surgeon that goes into the operating room, and then the surgeons fill out a accuracy form afterwards, and they get to knock us down points if we're off by 1 millimeter. So within 1 millimeter's accuracy, comparing 3D printed models to surgical observation for accuracy. The next number of cases to follow is just going to be a cornucopia. I will encourage you not to get into the weeds of the anatomic details because each of these cases we could probably talk about for 20 minutes or so, but just to give you a flavor of what some of these applications can be. So again, another patient that we're showing with a classic Glenn and a Glenn that was essentially ultimately a Fontan and a heavily calcified Fontan circuit. We suspect a very inefficient Fontan circulation with cyanosis. Very difficult to see with echo, and even some of the MRI images that we had shown better with 3D models. This is a very interesting patient. This is from WashU, who had been called a crisscross heart her whole life. This is a 45-year-old. We scanned her because she was getting progressively cyanotic. Come to find out that she was developing subpulmonary stenosis, and also come to find out that she's not a crisscross to begin with. So the diagnosis that she's been carrying for 45 years, we revised. She ends up being a complete AV canal with a double outlet right ventricle and subpulmonary stenosis right here. Hopefully you can see my cursor. And we think this subpulmonary stenosis was leading to her progressive cyanosis. So in this case, not just clarifying the anatomy, but hopefully giving our surgeons more of an idea of what to do about it. I'll show you one case where we used it directly for surgery and felt to be pretty helpful. This is a patient with double outlet right ventricle who had been repaired with a Rastelli procedure. So for the trainees, Rastelli is baffling the left ventricle shown here in pink across a VSD over to the aorta, and then a right ventricle to pulmonary artery conduit. So this is the clamshell view, kind of a coronal-ish view, and this on the right is the axial view or a surgeon's view, and the conduit is shown in green. If you can see down here on the axial view, this green is the same here, which is the VSD patch, and this patient had progressive exercise intolerance. What we're showing on this 3D model is that there is a complex left ventricular outflow tract obstruction. I've put a catheter through this model basically to show that there is a VSD, and what we suspect happened is that the VSD patch is buckled in, and there is now a residual VSD, and over time a muscle bundle has formed under the aortic valve that you can see right here. And we suspect that this patient's progressive intolerance was due to severe subaortic obstruction, which we knew from cath. However, this patient was facing his 6th open heart surgery. He's had a bunch of conduit replacements and also prior interventions on his LVOT. So a very high risk surgical candidate. And that is why we 3D printed the model, to really get a good sense of what the mechanism of obstruction is before we go in and operate again. And this is the view from the OR. You can see here again, looking down the aorta, here's the VSD patch. In the aorta, in the OR preoperatively, here's the VSD patch. Indeed, it had buckled in. There was a lot of muscle bundles under it. So our surgeons went in, took everything down, took down the VSD patch, took out the muscle bundles. The patient unfortunately developed heart block, which we knew was a risk factor going in, already had partial heart block, but actually felt much better as far as the exercise intolerance issue afterwards. Gonna switch gears a little bit, talk about 3D printing for percutaneous interventions. And this is one of my much older cases, probably about 6 years ago, showing a pretty simple concept. One of our patients with tetralogy of Fallot who's had a repair. So obviously this patient after TET repair has free pulmonary regurgitation shown in this cine image here. And now this group knows well, a lot of our TET pulmonary valve replacements are done by the percutaneous procedure if they meet certain parameters for size. And for this patient, we felt that the RVOT may be a little bit too big and patulous to safely put in a percutaneous Edwards or Melody valve. But the patient was borderline. So we thought, okay, let's go ahead and 3D print, which we did. And the 3D print allows us, I'll just skip the model, digital model, and just show you the physical 3D printed model. The 3D printed model was printed in flexible materials and also printed in systole, so that we're giving you the maximal dimensions across this MPA and also the RVOT. If you look closely here, you'll notice there's a bare metal stent that our cath doc has implanted, so a simulated procedure, and got measurements and felt that, you know, that could be a good landing zone for an Edwards valve. And this is the same patient after deployment of the Edwards valve within the bare metal stent, and a good result, no residual PR. So we're able to avoid open heart surgery in this patient. The patient went home in 2 days. This is a patient that Mahadvan brought to us, one of my favorite cases to date. Patient with the sinus venosus ASD, so and partial anomalous pulmonary venous return. 69-year-old patient. So the question was, could we do a covered stent procedure to essentially close off the sinus venosus ASD and redirect anomalous pulmonary veins across the ASD through a covered stent into the LA. So here we're dealing with not just complex connections, but also it's a question of size. So we made a 3D printed model off of the CT. And here's the planning session with Mahadvan. And this is my division chief, Phil Moore, who many of you probably know. He's also an interventional cardiologist who enjoys these challenging cases. And this is them on the planning session where they're making some pretty meticulous measurements of what size stent they may need, distance from SVC, et cetera, et cetera. And this is a different example of how we visualize these hearts. This is kind of a fiber optic camera, cheap camera off of Amazon, but shows really nice views for the intraluminal structures. So once we've printed a 3D model, we can essentially do a cath on it, if you will. Obviously no fluoro, but we can look with the camera inside the heart, get a view of all the potential connections and anatomy, and then do the procedure. But to cut to the meat of it, Dr. Mahadvan was able to put a nice long covered stent across this defect, essentially closing off the sinus venosus ASD and redirecting the anomalous pulmonary venous blood flow into the LA. Then you'll see the blood flow going out the aorta, left atrial appendage. Looks like here a good result, no residual defect, and there was no SVC obstruction either. So very nice result. And the 69-year-old being able to avoid surgery, I think it's a nice win. Transitioning from adult congenital a little bit straight into the adult structural world. This was a referral to us from a colleague in New Zealand, an 81-year-old patient facing a TAVR procedure with, as you'll see, a very heavily calcified aortic valve and a supravalvular region, and also a lot of calcifications all over the place, coronaries, mitral annulus, et cetera. The patient actually was severely compromised from the renal standpoint, felt to be a very high-risk surgical candidate. So the question was, you know, how amenable is anatomy for a TAVR? So, you know, for us, this was pretty straightforward because a lot of what we deal with is complex congenital anatomy. But of course, not to minimize the risk of this, you can see on this CT image here, all the calcifications, I'll just back up the CT image, all the calcifications across the patient's aorta, aortic valve leaflets, and then I'll pan across the images on the right, again showing calcifications. You'll see calcifications in the coronaries. So not the most low risk TAVR placement procedure. So we printed everything out. Here's a cross-sectional view of that same anatomy. All the bright spots are what we think are calcifications. And we also gave them a sizing guide, essentially. All the material data sheets are available from the manufacturer, so we can basically make sizing rings for how big the valve is going to be when you put it in. And this is just a snapshot of our virtual surgical procedure. We packaged up this model, sent it to New Zealand, but obviously our planning was done via Zoom. So kind of difficult, maybe a little bit difficult to interpret, but I'm showing a cutaway view of one of these sizing guides as we're inserting it into the aorta. So here's the aortic root with the coronary coming off. This faint yellow structure here is the mitral valve. And I'm cutting in and out of the LVOT. I'm not showing the LVOT here, but you can also get a sense of how the valve may sit with the LVOT mitral valve and get a good sense of this procedure in advance. The cath team there found this to be very helpful, proceeded with the TAVR procedure, and I'm happy to say that she did well. Just a quick look at what the limits of this technology are right now. Some of our colleagues, this is from Methodist Debaki, are essentially hooking up flow pumps to 3D printed models, specifically looking at aortic valve disease and driving flow through it and then echoing it. And this here on the left is a Doppler of the patient's own anatomy and the same Doppler from the 3D printed model, simulating the flow conditions. So people are getting pretty advanced as far as integrating not just the anatomic modeling, but also predicting the physiology pre and post procedure. The next couple of cases, I'm going to be pretty fast also, but it's really just meant to show you kind of a buffet of the potential applications of these technologies. This is one of our most recent cases. Minutes. Perfect. I'm going to finish in 5 and leave 5 for a Q&A if that's okay, Joyce.
Yeah, sounds good.
So this is our most recent patients referred to us because the patient has an intramyocardial LAD. You'll see the LAD come off the right coronary artery. Anomalously, it'll dive into the RV right there and then come out the other side and continue being the LAD. So the question for the congenital group was, can we go ahead and unroof this, or does the patient need a bypass? Dr. Reddy, our congenital surgeon, approached me to make a 3D model, and essentially this is what we found. Here's the right coronary artery coming off the right coronary cusp. Here it is diving into the right AV groove. Here it is diving into the RV. This is a better wall. Basically, I've removed the RV free wall. Now we're seeing the intramyocardial course of this right coronary artery. This is all in the RV heading towards septum. And this is where the LAD comes out and then courses along the septum. There. So 3D model showing exactly what the anatomy is. And looking at this 3D model, Dr. Reddy's concern was, if you go ahead and unroof this intramyocardial portion, oh, by the way, the patient was having chest pain, so we think that this could be coronary related. And the concern here was if we unroof this, which we could do technically, but as the coronary exits here, there's going to be issues with bleeding for the unroofed portion into the heart. So we referred this back to the structural heart disease group to say that this patient may be better served with bypass procedure. All right. We're using this for VAD planning, as I've shown, and this is just an example of kind of one of the more extreme applications of VAD planning, where we printed out the entire anatomy, chest included, took the 3D printed model into the OR, did a device implantation. This is just for proof of concept. This is pretty early on in my work. So this is just to show accuracy and proof of concept for VAD planning. And we presented this at the AHA a couple of years ago, but this is essentially the limits of the technology. It really simulates reality, we think, pretty well. Another example of a high-risk case, squarely in the adult structural world. So I've transitioned now from adult congenital to adult structural. This patient had had an aortic valve replacement and had a lot of work done in the aortic root, but also in the ascending aorta area. You can see the patient's got a graft. And to the cut to the chase, this patient has had this pseudoaneurysm develop, all this in orange. And the question was, what do we do about this? It's a pseudoaneurysm, so we could potentially do a cath-based procedure. And here I'm showing the mouth of the pseudoaneurysm, potentially to block off any entrance into the pseudoaneurysm. But where's that picture? But the issue is, as the pseudoaneurysm kind of goes around the aortic root, this is one of the coronary arteries that's right in the middle of it. And you'd really have to hold the model to appreciate it. But the concern was, if we put in a device here, the device will basically, as it expands, impinge on the coronary, causing probably a catastrophic event. So in this case, we diverted the patient more towards surgery, obviously a very high-risk surgery because the patient's had several already, but for decision-making, this was very helpful. I'm going to end the talk here, and if you want to read further about some review articles or places where you can find other references, you can screenshot this page. One shamelessly is from my own group here, ACHD in 3D printing. And another, the Stephen Little publication was excellent, cardiac 3D printing. This relates to structural heart disease applications of cardiac 3D printing. And then an upcoming publication from our group here at UCSF on ACHD interventions. So I'll just close by saying that I'm looking forward to getting to know your group better. My email is here. Feel free to reach out with any questions, or if you have interesting cases, I'm always happy to engage. And I'll just open it up for discussion.
Thank you so much, Dr. Anwar. I'll see if anyone has any questions. You can just unmute yourself. We're no longer in the webinar format, so it's a free call.
I'll also take my background off to introduce you to Michael Bunker. I'm actually sitting here in our 3D printing center, and Michael is our engineer. A lot of the work that we did, he gets the credit because we did it together.
Thanks for joining us. I see you on the call too.
Oh, we got 5 minutes. I'll take Q&A.
Okay, I have a quick question. So has this technology replaced the invasive imaging that we do with TEEs, or do you foresee it happening? Or do you still think that there are specific benefits to TEE that will, always make it necessary when it comes to planning? Yeah,
as I sort of alluded to at the beginning of my talk, I am modality agnostic. And I consider these 3D plus technologies to be an extension of one of our modalities. So I consider the information that we provide to be additive. I really think it depends on the cases. And, I'm a clinical person, I'm 80% clinical. So it really depends on the patient and the question at hand. So just like we pick transthoracic echo, TEE, nuclear, or cath, this is the same thing. The difference being, this takes off where some of those modalities leave off. So if we get a CT, it's no extra burden on the patient to do this because all of this is done as post-processing. So I don't really see this as an either or. I see this as complementary.
Thank you. I mostly ask because of, even though the TEs are generally low risk, it's always nice to say, well, now we have something that gives us similar or better imaging. Dr. Bolger has a question. Do you plan to incorporate 4D flow from phase contrast MRI in your models or high resolution CFD for planning? I personally don't know what CFD is, so if you could comment on that part too.
Sure. Dr. Bolger, we haven't met yet, but we should. This question is close to my heart. So I do MRI. So 4D flow is certainly a strong interest of mine. And we are in what's called phase 4 of the evolution of our 3D center. And phase 5 is our planned sort of growth into the physiologic modeling space. So it's certainly, for me, a strong clinical and research interest of mine to expand more into 4D flow and then marry physiologic imaging, which includes obviously 4D flow and strain and other functional imaging, with the anatomic imaging that we're doing to produce much more comprehensive data sets. As far as CFD goes, I claim no personal expertise in computational fluid dynamics I believe I've got that acronym correct. But I'm familiar enough with the technology to say that that definitely has a place. CFD, much more engineering and labor intensive, and I think has to be focused to the question, but certainly.
Any other questions from anyone? This was a great talk. I definitely appreciate the cases that we see all the time. So it's really helpful to see how it's applicable.
Great. Well, I'm mainly Mission Bay based, but if you find yourself here, I'm on the second floor, room 2421, drop by. And as Michael was saying, best way to experience these models is by touching them, picking them up, and really the questions grow organically. Our work with Mohadavan happened because he really wanted to get a better understanding of the sinus venosus anatomy. And then we developed the technology around what his questions were. So we're pretty flexible and happy to talk.
Maybe we'll try to see how we can get some fellows up there during their congenital rotation.
Sounds good.
Well, if there aren't any other questions, I will let you guys go. Thank you so much for joining us. And thank you so much, Dr. Anwar. That was an amazing talk.
Sure. Thank you for inviting me.